welcome to Medical Dialogues. I am Dr. Nandita Mohan, and today I will be taking you all to explore the world of rare diseases. And my topic for today is amyloidosis. Now, to explain this in a little bit more detail, a little bit more depth, we have with us today Dr. Sanju Daniel John, who is an internal medicine specialist practicing in Ernakulam. He's an expert in the management of diabetes in patients of all the ages, and he also treats lifestyle diseases and infectious diseases. He graduated from Father Muller Medical College in Mangalore, Karnataka, with an MBBS and a Doctor of Medicine in General Medicine. For 3 years, he was an assistant professor in Kannur Medical College, and he also worked as an associate professor in the Department of General Medicine at Azizia Medical College in Kollam. So Dr. Sanju Daniel John has a long list of research projects and articles to his name. He also participated as an investigator in an international study for the International Journal of Recent Trends in Science and Technology, which basically aimed to observe and analyze the management study on thrombocytopenia associated with P. vivax malaria at a tertiary center in southern India. So we welcome you to Medical Dialogue, sir. It's really a privilege to be having you on board here with us today.
Thank you, Dr. Nandita. Thank you for giving me this opportunity.
Great. So, sir, over to you. We can, if you can just proceed and give us an in-depth knowledge about amyloidosis.
Good evening, all. So I'll be presenting on a rare disorder called as amyloidosis. So amyloidosis is the general term used to refer to the extracellular deposition of highly ordered fibrils called as the amyloid, of which is of very low molecular weight subunit of different varieties of proteins, and they get deposited in various tissues and organs. So amyloid was termed by earlier doctor called as Mr. Schleiden in 1830s. So what are amyloids? Amyloid proteins are misfolded and form insoluble fibrils, disrupting the normal organ functions. So most commonly affected organs being the kidney, the heart, liver, and other organs such as the central nervous system. It's a very rare disease and it affects around 8 to 12 people per million annually. It has got heterogeneous manifestations which I'll be coming to it. For example, patients will have unexplained loss of weight, loss of appetite, they'll have enlarged tongue, muscle atrophy. Yes. So those are some of the heterogeneous manifestations, and they can cause other organ dysfunction such as liver, kidney, cardiac, and central nervous system with GI manifestations also. It is definitely a delayed diagnosis because it is an unusual protein which is formed in the body which gets deposited in many organs. That is why there's a delayed diagnosis. And specialized diagnosis and treatment I'll be telling in short. So there are, based on the amyloid protein, there are different types of amyloidosis. That is amyloid light chain amyloidosis, which is the most common, and second most common being the wild type ATTR amyloidosis, which is involving the cardiac dysfunction. Then we have AA amyloidosis and hereditary amyloidosis. So clinical assessment and history. So based on the type of the precursor protein like the amyloid light chain or the AA amyloid, we have different clinical features. So based on the clinical features, I'll just elaborate few of them. In short, cutaneous manifestations such as waxy skin and easy bruising, then musculoskeletal involvement being enlarged tongues of the tongue and deltoids, then symptoms of heart failure, cardiac conduction abnormalities, gastrointestinal system manifestations being hepatomegaly, splenomegaly, renal disease involvement being proteinuria with or without nephrotic syndrome, then certain peripheral and autonomic nervous system involvement, along with unexplained weight loss, loss of appetite, and yes, and these are a few symptoms which we can get from a patient whom we are suspecting amyloidosis. Then we have the laboratory test, we have tissue biopsy, imaging studies, genetic testing, especially to find out hereditary amyloidosis. Then we have bone marrow biopsy, isotope scans. So then we have the gold standard for confirmation is the tissue biopsy. It helps in identifying the amyloid. So organ specific biopsies would be better. For example, if you want a biopsy to find out if it's a renal amyloidosis, it is better to get the biopsy of the kidneys. Then we usually can get biopsies from the fat pad, that is abdominal fat pad, or from the shoulder fat pad. Then we have blood and urine tests such as serum protein electrophoresis, urine protein electrophoresis, then free light chain proteins such as kappa proteins. Then we have echocardiography and imaging studies such as CT scan, and then we have bone isotope scans. So the when we come to the pathophysiology, it is basically amyloid protein formation or amyloid fibril accumulation in the organs. What happens is there will be mechanical impairment and interference with the normal cellular function, which leads to impaired blood flow and leads to a chronic inflammation and an immune response. So in kidneys, what are the manifestations in kidneys? Amyloid deposits in kidney common. It's common in AA and AL amyloidosis. Deposits accumulate in the glomeruli and the tubules, leading to kidney function. Impact on the function: it results in proteinuria and may progress to nephrotic syndrome, causing swelling, high cholesterol levels, and kidney failure. Amyloid deposit in the heart, that is the transthyretin amyloidosis. It's common in AL and ATTR amyloidosis, both wild type and hereditary type. So deposits accumulate in the myocardium and blood vessels. It causes diastolic dysfunction, that is impaired relaxation of the heart, and can also cause heart failure, arrhythmias, conduction abnormalities, and restrictive cardiomyopathy, where the heart walls become stiff. Nervous system involvement: the amyloid deposits in the nerves, which is seen in ATTR hereditary form. It deposits affect both the peripheral and autonomic nervous system, causing peripheral and autonomic nervous dysfunction. Then liver and spleen. It can accumulate in the liver cells and spleen, causing its enlargement, such as hepatomegaly and splenomegaly. And this can also lead to cirrhosis or hypersplenism. Gastrointestinal tract: the amyloid deposits in the stomach, intestine, esophagus can lead to gastrointestinal motility disorders, diarrhea, malabsorption, weight loss. It may result in dysphagia because it involves the esophagus. Now, the treatment, it involves targeting the underlying causes. For example, amyloidosis is a disease of chronic inflammation. So we have to treat the disease of chronic inflammation, such as multiple myeloma or any Waldenstrom's macroglobulinemia or anemia of chronic disease. Then organ specific supportive therapies, certain immunotherapy drugs, symptom management, and multidisciplinary care. Next, we come to the chemotherapy in systemic amyloidosis. So there are certain chemotherapy drugs which can help in targeting these amyloid proteins, and in they help in targeting this AL amyloidosis. So examples of certain drugs being patisiran, then we have vutrisiran, and there are certain RNA targeted therapies. Then we have autologous stem cell transplant, where high dose chemotherapy eliminates amyloid producing plasma cells and stem cells are infused to restore both bone marrow function. Combined effectiveness, where there is combination of chemotherapy as well as the autologous stem cell therapy. Then early diagnosis is always better. So when do you suspect amyloidosis? We have to suspect amyloidosis in patients with heart failure without any reason, or proteinuria without any nephrotic syndrome, and and symptoms of chronic inflammation. It involves a multidisciplinary care, because if it involves renals, we require a nephrologist. Sometimes we require a cardiologist, a hematologist, and hence a multidisciplinary care. Then symptomatological management, for example, patients with unexplained weight loss, unexplained loss of appetite. Yes, definitely tiredness. We require hematological management. The recent advances in amyloidosis being gene editing techniques, that is, the CRISPR based therapies, which are under investigation for hereditary transthyretin amyloidosis. Then, novel stabilizers, which is an ongoing research on the improved drugs to stabilize the transthyretin. Cardiac imaging, advances in the cardiac MRI and nuclear imaging for early detection and monitoring. So the general approach being early detection of amyloidosis, being any type, being AL, AA, transthyretin type. The management of renal amyloidosis is very important. Proteinuria control with ACE inhibitors, ARBs, kidney function support either conservative or by dialysis, and dialysis also. There is a term called as dialysis dependent amyloidosis, which can also be found because of the accumulation of beta 2 microglobulin. Then management of liver dysfunction, amyloidosis, liver function monitoring should be done. Symptomatic treatment and advanced liver disease, patients may require organ transplant. So preventing further organ damage, what do? We have to avoid nephrotoxic or hepatotoxic drugs. Nutritional support is very important, and regular monitoring of the renal and kidney functions. So, challenges in managing patients with amyloidosis. First, for a challenge we find is early diagnosis is a challenge for patients with amyloidosis, because patients most of the time they have certain symptoms which do not pertain to amyloidosis, and once these patients are are having symptoms of chronic inflammation, then only they get diagnosed. So it is challenges we face in amyloidosis, the early diagnosis. Then disease heterogeneity, definitely and it involves many organs, so disease heterogeneity comes into play. Then advanced organ damage at presentation. Yes, certain patients, when they have advanced organ damage, we may have to take up the patient for some organ transplant. Then along with that, we may have to manage comorbidities such as diabetes, hypertension, dyslipidemia. Treatment challenges, definitely it can be due to financial, or it may be due to availability of the medicines. Then monitoring and follow-up is very very important, because we need to monitor especially the hematological counts, the liver function counts, and renal function counts. Emotional psychological impact, definitely it's a disease of chronic inflammation, it takes a long time, so we need to have emotional and psychological help for such patients. And there is, as you have seen, there are only limited research on these on the drugs for amyloidosis, and clinical trials are going on for this disease. Thank you so much. This is all about amyloidosis.
Thank you so much, Dr. Sanju, for joining us today and giving us all your valuable insights on this rare disease. And it was very insightful and a very detailed presentation. I would definitely tell you that. So, thank you once again for joining us today at Medical Dialogues.
Thank you. Thank you, Dr. Nandita.
Never miss a medical update from Medical Dialogues. Like, subscribe, and press the bell icon.